Metabolic syndrome is a Cushingoid precursor. This is the topic of my talk today. In fact, they are mutually connected. Metabolic syndrome is quite common in Cushing syndrome and vice versa. Cushingoid presentation is common in metabolic syndrome. So definition-wise, metabolic syndrome is an insulin-resistant state that we all know. And insulin resistance, hyperglycemia, elevated blood pressure, abnormal lipids, and abdominal obesity. These are the constellation of symptoms and features of metabolic syndrome. This increases the risk of cardiovascular disease and type 2 diabetes, especially with the obesity pandemic across the globe. Definition-wise, if you look at obesity, the Indian subcontinent and Asian subcontinent, the obesity cutoff by body mass index is very different. And in the Indian subcontinent, anybody with a body mass index of more than 25 is considered as obese. Whereas in the Western world, more than 30 is the cutoff. So it's always better to take abdominal adiposity as the important risk for metabolic syndrome. And if you have two additional diagnostic criteria, either diabetes or prediabetes, elevated non-HDL cholesterol level, high normal blood pressure, or hypertension. It can be in different forms, as you can see from the slide. I'm trying to cut short because of the time constraints. So if you have abdominal adiposity or increased body mass index, along with 2 or 3 additional diagnostic criteria mentioned here in the slide, indicates metabolic syndrome. In fact, it is part of the obesity pandemic, and more than 30% of the Western world is already obese, and that's going to be more than 40% in near future in Americas as well as in the Europe. So this causes the problems in metabolic syndrome, such as prediabetes or diabetes, hypertension or high normal blood pressure, and atherogenic dyslipidemia, which tremendously increase the cardiovascular risk. Metabolic syndrome and abdominal adiposity can be associated with a lot of illnesses in every organ system in the body, which can cause abnormal kidney function, metabolic associated fatty liver disease, heart failure with preserved or even reduced ejection fraction, sleep apnea, polycystic ovary syndrome, sympathetic overactivation and tachycardia, hyperuricemia, which all result in a chronic inflammatory state that is associated with the syndrome. Looking at the evidence, if you consider cortisol as a precursor for metabolic syndrome, as you all know, cortisol as secretion depends on the hypothalamo-pituitary adrenal axis and the circadian rhythm of cortisol production and the level of 11-beta hydroxysteroid dehydrogenase levels. The 11-beta HSD1 catalyzes the conversion of inactive metabolite cortisol to active cortisol, and it also amplifies the good glucocorticoid receptor activity. Whereas 11-beta HSD2 catalyzes the conversion of cortisol to cortisone. This is mutually regulated. In fact, obesity and insulin resistance are associated with increased expression of 11-beta HSD1 levels, whereas suppressed expression of 11-beta HSD2 levels. This increases the local cortisol levels. As you can see from this schematic representation, cortisone in the presence of 11-beta HSD1 is converted to cortisol, which is the effective steroid hormone, acting on the glucocorticoid receptors, effector cells, increasing the... Are you okay? Right. Increase the gene expression and also the effector in the effector organs. Cortisol is converted to cortisone, and it's the loop we can see. So cortisol binds to the cortisol receptors in the glucocorticoid receptors. Inactivation of the circulating cortisol by 11-beta hydroxysteroid dehydrogenase 2 in the kidney, and reactivation in the peripheral tissues as shown in the diagram. So glucocorticoid receptor-induced local activation also can occur, increasing the intracellular cortisol availability. In fact, metabolic syndrome is associated with increased activity of the 11-beta HSD1, and that results in increased local steroid response and increased HPA axis activity. The resultant raised tissue as well as systemic cortisol levels play an important role in the development of metabolic syndrome. As I mentioned initially, they are mutually connected and mutually complementary. If we have something to stop the activity of 11-beta HSD1, it may have therapeutic effect in obesity and metabolic syndrome. Obesity is also associated with increased gene expression of 11-beta HSD1, and that increases the subcutaneous adipolysis, increase the HPA axis-driven cortisol secretion, and these effects can be restored by bariatric surgery and loss of weight. These are all recent evidence coming up in the horizon. Cortisol may have a pathogenic role in the development of central adiposity, as described by Bujalska et al. In early 1990s. They analyzed the cultured omental as well as subcutaneous tissue adipose stromal cells, finding exclusive expression of 11-beta HSD in these cells. This increased activity of 11-beta HSD in the omental fat compared to subcutaneous fat led to the proposal that visceral obesity is a Cushing syndrome of the omentum. This increased local cortisol generated will increase the adipolysis and promotes pre-adipocyte differentiation of adipose tissue, increasing the adipocyte hypertrophy and consequently result in obesity. If you look at Cushing syndrome, that causes metabolic syndrome because of the abnormal the activity of the cortisol in tissues. And if you estimate if you measure the plasma, salivary, and urinary cortisol, because they are all having short half-life, you may not be always able to identify subclinical Cushing. However, if you look at scalp hair, which grows at a rate of only 1 centimeter per month, it may show increased cortisol levels in the scalp hair. And it has been found that increased cardiovascular risk, diabetes and metabolic syndrome and obesity are seen in those with high hair cortisol levels. Cushing syndrome, again, as I mentioned previously, can cause the metabolic syndrome phenotype by increasing the abdominal adiposity, increased association with hypertension, diabetes, dyslipidemia, and metabolic syndrome at high prevalence rates. Glucocorticoids increase the levels of glucose and increase hepatic gluconeogenesis, disrupting the insulin signaling in the liver, skeletal muscle, adipose tissues, and consequently increased glucose disposal, decrease the glucose disposal in the periphery, resulting in diabetes. Chronic glucocorticoid excess promotes accumulation of fat deposits in the liver, skeletal muscles, and pancreas. All those things can lead on to visceral obesity in Cushing syndrome patients with a very high prevalence of 25 to 50%, 100%, especially if it is slow, indolent, and chronic. Visceral obesity in Cushing's disease is associated with increased adipocyte hormones. It's also associated with increased metabolic activity, resulting in increased cardiovascular risk. Chronic glucocorticoid excess also stimulates lipolysis, mobilization of the subcutaneous fat tissue, and increased ectopic fat distribution in the form of buffalo hump, abdominal adiposity, and central obesity. This is a schematic representation of the adipocyte biology in Cushing syndrome with the steroid excess. You can see there is reduced brown adipose tissue, which is calorigenic, which is metabolically active and metabolically healthy, whereas you have abnormal lipid accumulation in different tissues, increase in the activity of 11-beta HSD1, reduced lipogenesis, increased lipolysis, and an inflammatory state. It also increases the food intake by hypothalamic stimulation. It can cause hepatic steatosis. It can worsen the pancreatic function, reducing insulin secretion, incretin secretion, and increasing glucagon production. It can also increase visceral fat tissue deposition in the epicardial fat tissues. This is the picture which shows the interconnection between abnormal glucocorticoids and metabolic syndrome. I'm not going to the details of that because of the time constraints. So metabolic syndrome causes hyperglycemia, dyslipidemia, central obesity, and hypertension, which in turn causes the structural and functional changes in the cardiovascular tissues. It causes increased coagulopathy, atherosclerosis, vascular remodeling, endothelial dysfunction. All these things increases the cardiovascular risk. Even treated cases of Cushing syndrome can be associated with increased CVD risk because the metabolic abnormalities and the obesity wouldn't go immediately after the treatment. So you have to be very careful with this kind of patients. We can there's clear evidence that there's increased aldosterone production in patients with metabolic syndrome. Maybe one of the reasons for hypertension in these patients. So there is inappropriate aldosterone secretion from the adrenal glands, local adipose tissue production of aldosterone possibly, and adipose tissue derived adrenal aldosterone secretagogue effect. Therefore, obesity is associated with increased mineralocorticoid production and mineralocorticoid receptor expression. Both cortisol and aldosterone and the receptor activation are important for obesity and metabolic syndrome. This is another graphical representation of how obesity involves increased aldosterone production and synthesis, resulting in hypertension. It has been found that mineralocorticoid receptor antagonists now in horizon. This is an important emerging concept. Treatment with mineralocorticoid receptor agonists in patients even with mild hypertension may have protective effect in cardiovascular health and metabolic health. And aldosterone synthase inhibitors are upcoming. There are a lot of new publications coming up. All those things should help us to improve the disorder, the metabolic syndrome, which is a Cushingoid state in a nutshell. So in summary, metabolic syndrome and Cushing syndrome are closely interconnected. Though there are several mechanisms mentioned previously, the exact pathobiological aspects of this new entity is still elusive. Appropriate control of obesity and adiposity by medical therapy, lifestyle changes, or bariatric surgery are the cornerstones of managing metabolic syndrome, especially if there is significant comorbidity, and it can improve the Cushingoid state. This approach should help to improve the cardiovascular risk, and appropriate use of medications, including mineralocorticoid antagonists, mineralocorticoid synthesis inhibitors, enzyme inhibitors, and appropriate treatment of obesity should help us to address the huge cardiovascular risk related to metabolic syndrome. Thank you.